Welcome to today's HealthLine Innovator webinar from the American Association of Kidney Patients, titled Advancing Vascular Access in Kidney Care, Challenges and Innovations. Thank you for joining us today. My name is Jerome Bailey, Director of Patient Engagement and Advocacy for AAKP. AAKP is pleased to host our Innovator webinar series, an extension of our normal HealthLine webinar programming. The content of this program, as presented, and sponsorship support of this webinar is provided by Xeltis. As the oldest and largest patient-led kidney patient organization in the U.S., AAKP is proud to host this Innovator webinar as a service to the expanding national and global communities of patient consumers and their families, medical practitioners, researchers, and policymakers following innovation and advancements in kidney care and treatment. AAKP is an aggressive supporter of innovation to change the status quo of care. While this activity is an approved educational and informational webinar containing branded content, AAKP does not endorse specific commercial entities or products. Thank you again, Xeltis, for supporting today's programming. AAKP's HealthLine and HealthLine Innovator webinars fall under our Center for Patient Research and Education. We believe patient and care partner education is an integral part of an individual's treatment, and to that end, AAKP is a champion for full patient care choice, the protection of the patient-doctor relationship, and the elimination of artificial barriers and government determinants of health that impede access to all available treatment options. Through our initiatives, we aim to ensure that patients have a central voice in research and innovation. By leveraging lived experiences and unique insights of the kidney patient and care partner communities, we help drive meaningful advancements across the entire product development lifecycle, from identifying unmet needs and informing clinical trial design and development to shaping regulatory pathways and supporting value, access, and reimbursement decisions. As medical science progresses with personalized medicine, cutting-edge technologies, and novel treatments through this decade of the kidney, the potential for better outcomes in kidney care has never been greater. Patient safety has always been a cornerstone of AAKP's mission and remains closely connected to today's discussion on vascular access. In 2024, AAKP launched our National Safety and Emergency Preparedness Awareness campaign titled Every Patient Safe. This multifaceted effort focuses on the unique risks and safety needs of vulnerable kidney patients and kidney transplant recipients. Those risks include ongoing susceptibility to serious COVID infection and premature death, increased vulnerability to healthcare-acquired infections, and catheter-related bloodstream infections among hemodialysis patients, future pandemics, and disruptions caused by sudden natural and unnatural disasters. Today's webinar focuses on one of the most critical and often challenging aspects of dialysis care, vascular access. For patients receiving dialysis, vascular access is truly a lifeline. Yet, it also remains a major source of complications, including infections, hospitalizations, repeated procedures, and disruptions to quality of life. As innovation continues to shape the future of kidney care, new technologies and approaches are emerging with the potential to improve both patient outcomes and the dialysis experience. Leading up to today's webinar, we gathered feedback and insights through a flash survey focused on patient and care partner experiences with dialysis access. This independent survey was conducted through AAKP's Center for Patient Research and Education and reflects real-world perspectives of patients and their loved ones living with and experiencing access-related challenges every day. To walk us through what we heard, I'd like to introduce AAKP's Vice President and Chair of Policy and Global Affairs, Paul Conway. Paul is a passionate advocate for patient-centered care, patient participation in true shared decision-making, and the use of patient insights in kidney research. As a kidney disease patient himself for 49 years and a 29-year transplant recipient, he has been recognized for his advocacy work with several national awards, including the President's Medal from the American Society of Nephrology and the Presidential Volunteer Service Award for Lifetime Achievement. Paul has served in 4 U.S. presidential administrations, including as Chief of Staff for the U.S. Department of Labor. He was selected by the FDA to serve as the inaugural chair of the FDA's Patient Engagement Advisory Committee and has served on the American Board of Internal Medicine, Nephrology Specialty Board, as well as multiple CMS technical panels related to dialysis quality improvement measures. Paul joins me now. I welcome you to the program, Paul.
Hey, Jerome. Thank you very much. And thanks again for another fantastic webinar here on an issue that's vitally important to kidney patients. We're talking about dialysis access, and this is the connection between you and your machine that for life-saving treatment. And it's fundamentally important to make certain that dialysis access is talked about. And as we go through this data, you'll see that conversations between patients and healthcare professionals happen, but they don't happen as frequently enough. And with the amount of innovation that's happening in this space, we think more conversations should happen so patients can exercise their free choice. Let's go ahead and take a look at some of the data that we have here. And again, this was put out by our Center for Patient Research and Education, which does a substantial amount of polling and survey work in the kidney community. We asked for the respondents how best to describe themselves. You see 42% indicated that they do in-center hemodialysis. 24% indicated that they have chronic kidney disease and they expect to do dialysis. 11% were caregivers, had 7% that were peritoneal dialysis, and you had about 10% that were on home hemodialysis. We asked how long have folks been on dialysis, including current and former types of dialysis experienced. Less than 1 year, about 24%, 1 to 3 years, 20%, 4 to 7 years, 14%, 8 to 10 years, 5%, more than 10 years, 9%, and for those who had not started dialysis yet, 27%. This is a pretty representative sample in a tribute to our staff reaching out across all different types of modalities and time on dialysis. We asked either before going on dialysis or while on dialysis whether or not patients had expressed an interest in receiving a kidney transplant to their care team. 67% said yes, 29% said no, 4% said they didn't remember. The next slide is where it gets interesting. So we asked a follow-up question, are you presently listed on the National Organ Waiting List for a kidney? 19% said yes, 78% said no, 3% didn't know. This is not atypical from some of our polling and survey work. The aspiration to be a transplant recipient is quite high. How that translates, though, into being on the waiting list is a challenge. It can be a challenge medically. It can also be a challenge in the communications with the dialysis facility professionals and medical professionals in terms of getting listed. We keep track of this issue very closely at AAKP. We ask folks when they receive their current access. Prior to needing dialysis, just about a third. After first having a dialysis catheter, 25%. After another access option failed, 20%. And for those who had not yet received a dialysis access, about 23%. Let me point out one thing that's very important here. The 25% that received after having a dialysis catheter, just keep in mind that half of those who are on dialysis go to dialysis from an emergency room, often on a catheter, because the advanced planning side of things simply does not afford itself in an emergency situation. These are folks that we're very concerned about in terms of being informed about what their choices are and being able to make a subsequent and informed switch to a different type of access. We asked, did folks discuss dialysis access planning before starting dialysis? For those who were able to, who are not in an emergency setting, 62% said yes, 32% said no, 5% were uncertain. We asked if folks had ever spoken to a healthcare professional about the advantages and disadvantages of the different vascular access options for dialysis. 67% said yes, 31% said no, 1% didn't remember. a very important point here. 31% are basically saying that they did not talk to a healthcare professional about the comparative advantages and disadvantages. This is your connection to a life-saving machine and treatment. We're trying to drive that number down to make certain that as many patients as possible are asking about their care choices and the advantages and disadvantages that go with them. That's what the webinar today is all about. We asked, do you feel like you understand your dialysis access options and are able to participate in decision-making with your kidney care team? So 51% indicated they knew their options and they felt like they were part of the decision-making process, which is excellent. You had another 21% that said they somewhat knew what their options are, but still felt like they were part of the decision-making process, and that's good. You had 12% saying that they somewhat knew their options, but didn't feel like they had any decision-making power during the process. And then you had 16% that said they didn't know what their options were and they did not feel like they were included in the process. Those last two numbers are very important. That's 28% of those that we surveyed felt like they had basically not been looped in to a key decision about their life-saving care. And we think that that is just wrong, and we have to educate folks, not only patients, but care professionals, to include the patient in the decision-making process. We asked what type of dialysis access options have you discussed with your care team or experienced? And this was on all. So you can see that 60% indicated they had experience with AV fistulas, 42% had peritoneal dialysis catheter, PD catheter experience. That's the abdominal tube that goes in. We asked on arteriovenous graft, AV grafts. 37% had experience with that. Central venous catheter, 35%. And as far as those who had not yet discussed yet, these are the folks that are early on and they're expecting to go on dialysis, about 12%. But you can see here that in the life cycle of a patient who is undergoing end-stage renal disease and treatment on dialysis, you will progress often through several different types of access. We asked, what type of dialysis access do you currently use for dialysis treatments? Here you have AV fistula, about a third, a CVC, central venous catheter, about 20%, an AV graft, 16%, peritoneal dialysis catheter, about 10%, and again, you have those who have not yet gone on to dialysis at about 22%. We asked how satisfied folks were with your current type of vascular access for dialysis. Very satisfied, 20%, satisfied, 25%, neutral, 17%, dissatisfied, 9%, very dissatisfied, 1%, not really applicable. Overall, it's a pretty good picture. About 45% are okay, but there are folks that are out there that probably need some more education, clearly, on what their options are for vascular access in order to improve their satisfaction level. We asked if you currently have an AV fistula, what has been the most frustrating aspect of your experience? And here, nearly a third talk about multiple procedures and interventions, cosmetic issues, and self-esteem. We hear this frequently, especially from women. The disfigurement of the forearm and your arms, communication with care team in terms of frustration ranks up there. So in terms of the picture, it's really the multiple procedures and interventions that registered the highest for AV fistula. We asked if folks had had surgery to treat complications related to current dialysis access. This was for all access. 37% said yes, 36% said no, 26% not applicable. This paints a picture of it's not always easy when we're talking about access, and there is a lot of adjustment that people go through in order to get it right for their treatments. We asked if folks had ever had an infection that was related to dialysis access. 15% said yes, 64% said no, and not really applicable, about 20%. We asked if there was a safer vascular access available to patients that allowed for easier and safer home hemodialysis treatments. Would they be more likely to consider home hemodialysis? This is in the category of new innovations that make home dialysis easier. 51% said yes, 26% said no, 23% were unsure. But we think this is a very important point for education because there are innovations that are happening that make hemodialysis and access easier. We asked if folks believe there's any value in a vascular access that prevents needle injury, such as bleeding and hematomas and pseudoaneurysms, the large bumps. That was one of the things that we had seen in an earlier slide where people feel self-conscious about that, or bleeding from accidental needle dislodgements. 74% indicated they'd be interested. 23% were unsure. We usually interpret that to be, with education, you might be able to move some of the people that are unsure. So you can see from this information, there's a wide range of experience that people bring to their dialysis treatments and their background with vascular access. What's very important for folks to understand is that AAKP is a longtime champion of patient care choice and greater innovation. This is a very optimistic time for kidney patients. There are a lot of innovations that are happening, a lot of things that the FDA has approved that Medicare is now paying for and private insurers. But as a patient, your life-saving treatment on dialysis is critically important, and making certain that you have the right options for access is vitally important, not only for your own satisfaction, your confidence in your treatment, but also for your long-term health outcomes and your transplant readiness. You want to be as healthy as possible while you're getting dialysis treatments so that if you have indicated that you want to have a kidney transplant, you can get one. And you've done everything possible, including the innovations that you're using during dialysis, to stay as strong and as healthy as possible. I'd like to thank Jerome again for this excellent webinar and for bringing this issue forward, because it is the life and death types of decisions that people make on their treatments and their treatment access that they have to manage every single day that we don't think people really focus on or get enough attention and concern about. So Jerome, thanks again for bringing this forward. Excellent webinar.
Thank you, Paul, and thank you for sharing the results of today's flash survey results. The survey results make it clear that patients value education, shared decision-making, and innovations that can improve both safety and treatment experience. Most importantly, they remind us that the patient perspective must remain central to every conversation about dialysis access and kidney care. I'm now pleased to welcome our first speaker, Dr. Carl Illig. Dr. Illig is Chief Medical Officer and Director of Research and Education at Flow Vascular. A nationally recognized vascular surgeon, his clinical practice is devoted exclusively to dialysis access. He has authored more than 120 peer-reviewed manuscripts, 70 book chapters, and several books, including Principles of Dialysis Access, a leading textbook in the field. Dr. Illig's current research focuses on dialysis access hemodynamics and advancing dialysis access education to improve patient care and outcomes. Dr. Illig, thank you for joining us today. I'll turn the program over to you.
Thank you very much. It's a pleasure to be here. I guess I'll start with a few slides on just sort of what the problems we're facing and how the Xeltis graft comes into play. So in terms of conflicts of interest, I'm an investigator in the trial, but I certainly have no personal financial benefit or equity or anything like that. Now, it's a small world. A semi-in-law of mine married my best friend's father. He's also my father's best friend. And they were married for 7 or 8 years. And it turns out that Jerry was a pioneer dialysis access nurse, heavily involved in patient advocacy, some political stuff. Knew Terry Litchfield well. We were at a wedding a few days ago, and she showed me an email she got advertising this webinar, and there was my face. So small world, and if anybody knows Jerry, hope she's watching. We'll see if we can get her to one of our meetings. So some background, chronic kidney disease affects about 1 in 7 US adults, and that is 50 million adults. 9 in 10 don't know they have it, and very worrisome, 1 in 3 adults with severe chronic kidney disease, the patients that we're all dealing with, don't know they have it at all. So about 800,000 US adults have end-stage renal disease, meaning transplant or dialysis, and this number has doubled in the last 20 years. And this is a slide looking at prevalence, and these are the total number of people on dialysis. Other than a little bit of flattening recently, which may have been some sort of COVID effect, you can see that line is as near to a straight line as you can possibly imagine. And since 2002, again, this number has doubled. This is the incidence, the new patients per year. And once again, although it's a little more jagged, this also mimics the prevalence, showing that every year more and more and more and more people are on dialysis. So this is a real problem. This is a heat map showing the areas in the world with the highest rates. I don't have a pointer, but I'm down in Houston, and so obviously right on the border of America and Mexico, which actually seems to have an even higher rate than the United States. And I thought it was kind of fun to see that Taiwan and South Korea are the only two other areas that beat the United States for prevalence of kidney disease. Of the 480,000 Americans who are on hemodialysis, about 70% have fistulas, about 25% have catheters, and about 15% have AV grafts. So what this really is for us is it's an absolute holy war. This is doing battle against renal failure, which is trying to kill everybody, and we're fighting the battle. Although in the modern era, it's a little more the good guys versus the bad guys. And of course, the classic series, not the new ones. So what's better, fistulas or grafts? Well, fistulas, you have to play the cards you're dealt. Your veins are your veins. It's also slower, less certain, more difficult to get up and running. But once they're running, as everybody here knows, they're the best long-term, they give the best long-term outcomes. And this is lowest rate of infection, greatest patency, and lowest rate of reintervention. By contrast, grafts, anyone can get one. They come right out of the box. They're quickest to get the catheter out. You can use an immediate access graft or wait 2 weeks for a regular graft to kind of seal. Catheter comes out pretty quick, but the long-term behavior is inferior to that of fistulas. They have a higher infection risk, higher reintervention rate, and higher failure rate. Now, for those who deal with science in a clinical setting, these graphs are kind of upside down, but these are really showing failure rates. So you can see in blue that at all phases, in all ways to look at this, in all measures of patency, AV grafts behave worse. They have a higher failure rate than AV fistulas. And interestingly, in A, it really becomes apparent that this is pretty similar early on, and then it diverges as time goes on. What should we do? It would be nice to have an access option that combines the short-term advantages of a graft with the long-term advantages of a fistula. So this is where Xeltis comes in. On the bottom left is the graft itself. It looks like any other graft, but the basic premise is that the molecules are engineered, bioengineered, so that they are gradually replaced by the patient's own human cells. And the time frame seems to be about 1 to 2 years, and that's basically the whole crux on which the Xeltis graft is in existence for. So this sort of heat map biological cartoon is a little bit hard to read at the beginning, but it basically illustrates the life cycle of the graft. Lower left is a regular graft. You've got thrombus and neoendothelium, which is bad on the lumen. You've got polytetrafluoroethylene in the wall itself. And then the upper left, after remodeling, you've got ingrowth of native capillaries, arterioles, feeding the native tissue that's grown in. And you have something that appears to be, so far, true endothelium. And endothelium, this has been shown histologically in animals and in limited patient explants in Europe. The basic premise is that after 1 to 2 years, the biomaterial is replaced by the patient's own human cells. And the goal is it gives you the advantages in the short term of a graft. You can just take it off the shelf with the long-term advantages of a fistula, thromboresistance, and better patency. There's some other advantages too. The tissue is engineered to be less compressive. And that middle line that shows bench, it resists that needle stick and takes it away from the back wall. Whereas you look down one, this is conventional PTFE, it's much easier for that to collapse, much easier to get a back wall puncture. Also, because you've got native tissue, the healing after decannulation or any other problems, healing is dramatically improved. And in theory and analogous to other strategies, this should result in lower pseudoaneurysm rate, lower infection rate, and better overall survival. So this all started with a pivotal trial in Europe, and I'm just going to show you a few results, not get bogged too down in the details. The patency related reintervention rate per patient year is between 1.1 and 1.3 per patient per year, and that is a pretty good number compared to what we see. On the right, these are historical numbers. PTFE reintervention rate is about 2.6 per patient per year. Other devices, catheters, for example, 3.3 patient interventions per year. And an AV, and this is even better, Xeltis is even better than the AV fistula, which is about, once it's matured, which is about 1.8 interventions per year. So the intervention per year related to patency so far looks excellent. By the same token, the clinically relevant access-related infections per patient year with Xeltis is about 3%, fistulas about 4%. And this doesn't mean that Xeltis beats fistulas by 1%. This means that Xeltis behaves like a fistula. Other devices, 9% PTFE grafts, and central lines up to about 22% per year. So the clinically relevant access-related infections, and again, Europe has been shown to be dramatically less than PTFE and essentially identical to those of fistulas. So the European pivotal trial demonstrated safe and easy implantation, low reintervention and infection rates compared to PTFE. Reintervention and infection rates were very similar to autologous fistulas. Cannulation was as early as 14 days, which is much better than fistula, is what we would expect out of a graft. And it becomes a vascular tissue conduit. And I would disagree maybe with pulsating. That means you've got an outflow obstruction. But it certainly becomes palpable, a vascular tissue conduit by about 12 months. The United States trial is ongoing. There are 50 or 60 patients enrolled. I don't think this U.S. map is accurate because it shows it shows various places but doesn't show Texas. We've got a couple places in Texas that are involved. High volume centers are in the range now of 15, 16, 17 patients. In our center, we've enrolled 7, and 6 of the 7 have done wonderfully and are very, very happy. And the 7th was probably an iatrogenic problem with the cannulators. So far, people are very happy, and these are behaving very, very well. So this is our life. As I said, it's a holy war. We are just trying to battle against the forces of evil that try to kill you with renal failure. And we are all excited. Xeltis is one of several recent innovations to make our job a little easier. And maybe if this works out, it's going to be a great thing for our patients. The benefits of a graft in the short term combined with the long-term behavior of a fistula. So far so good, and we'll see.
Thank you, Dr. Illig, for that informative presentation. Please stay with us as we have a few questions for you following our next speaker. It's now my pleasure to welcome Reginald Robbins to the program. Reginald was diagnosed with kidney disease in November of 2023 as a result of diabetes and unexpectedly crashed into dialysis after a rapid decline in kidney function. Having watched his mother undergo dialysis before her passing, Reginald faced his own diagnosis with strength, resilience, and personal understanding. Before kidney disease forced him onto disability, Reginald worked in the construction industry as an operations manager. Today, living in Houston, Texas, he hopes to use his experience to connect with and encourage others navigating dialysis and kidney disease. Please join me in welcoming Reginald to the program. Welcome, Reginald.
Thank you. Welcome.
Can you share with us what it was like when you crashed into dialysis and how that experience affected you physically and emotionally?
In November 2023, I was on a vacation for my birthday in Las Vegas, Nevada. Coming through the airport, man, I couldn't walk 10 feet without being out of breath. So I had to get a wheelchair to get back to the plane. I was confused. The doctor had already been telling me if I didn't get it together, I was going to be on dialysis. I was afraid of dialysis because my mother passed by being on dialysis. But the doctor kept explaining to me that everything had changed over the years and there was a better procedure and everything will be better. So when I came back from Vegas, I went to the emergency room. I stayed in the hospital 9 days. That's when I got on dialysis. But I feel 100% better being on dialysis than what I did prior to getting on dialysis. So, hey, I don't knock it for nobody. Everybody, think for themselves. But for me, it saved my life.
Can you talk about how your previous access impacted your daily life, comfort, or dialysis treatment?
Actually, it didn't impact my life at all because it was underneath my shirt. Didn't nobody know I had it. Uh, it was okay with me. Only problem I had is coming to dialysis 3 times a week, 4 hours a day, and that took away from me working.
What concerns or questions did you have when you first learned about the access from Xeltis?
I wasn't familiar with it at all. So when they was explaining it to me and asking me did I want to try, uh, I was like, hey, it doesn't matter to me because I wasn't familiar with what was going on. And when they was explaining it to me, and by where they was gonna place it at, it wasn't visible to everybody that's gonna see it. So I agreed to to do the trial period with it, and I'm satisfied with it. I love it. I would recommend it to I recommend it to people now.
Since receiving, the new access, have you noticed any differences in your dialysis treatment or your quality of life?
Well, I haven't noticed any differences in my dialysis treatment, but my quality of life I have because I mean I can't speak on how the other accesses work, but the one that I have, I feel like it worked 100% satisfactory. And like I say, I recommend it to people all the time. So yeah,
So, last question for you. What advice or encouragement would you give someone who is just starting dialysis or struggling with, access related complications?
I feel like if they're not happy with the access that they have, maybe they need to check and see if there's anything available that they can try different to where they won't keep their spirits down. Because I come to dialysis, when I leave dialysis, I feel good. I'm not tired or none of that. And I see a lot of other people come to dialysis that leave out, like they being beat down or whatever. So I don't understand that. I think it's a mind game, but I feel like if it's other accesses available, you should be given the opportunity to choose the one that you want instead of them just telling you, well, you're gonna get this one or you're gonna get that one.
Thank you, Reginald, for sharing your dialysis access experience. I'd like to bring in Dr. Illig back along with Reginald to answer some questions we received from audience members as they registered for today's program. So our first question is for you, Dr. Illig. We often hear the term restorative or regenerative technology associated with access. What does that actually mean in practical terms for patients?
Well, again, we're essentially regenerating or restoring the patient's native tissue within the inside of the graft. And in its nuts and bolts sort of basic meaning, it really means that you're getting a graft that is lined by human tissue. And that means it's going to be better patency, lower thrombosis rate, all those good things that we like to see. So what we hope it's going to mean in a practical sense for the patients is fewer trips to the operating room, more success to start out with, and better patency, lower infection, which absolutely will result in a longer lifespan.
So, Reginald, this question is for you. Looking back, what do you wish you had known earlier about dialysis access and treatment options?
Well, I wish I would have known to do the right thing where I wouldn't be on dialysis. But being that I am on dialysis, and I wish I would have known, like I had said earlier, different access points, before a person should, have a choice as to where the access going to be or what procedure they going to take, because like I said, it affects everybody different. So, yeah, I feel like everybody should have a choice. They shouldn't just have one particular access available.
Now, another question we have for you, Dr. Illick, is this technology designed for certain types of dialysis patients?
The type that are on dialysis. It's really applicable to any dialysis patient who can receive hemodialysis. Now, there are some people who can't. The heart gets overstressed in some cases, but really anybody that can receive a dialysis access graft can use this device. I think that if it does turn out to be as promising as early results showed, everybody should be getting it. It's the economics are always important, but if we could finally get a graft that truly does improve patency and reduce intervention rates, then there's no reason why everybody couldn't get it. So there's no specific patient that can or can't get any graft, and certainly no patient can't get this graft. So I'm hoping that it's going to be applicable to everybody.
Can you describe, your experience transitioning to the new access?
Like I said, I was afraid of needles. So by them using this mesh access, you really don't feel it as bad, I guess, as the other accesses. Because I hear people being dialysis hollering, saying that it hurt, this, that, another. But the access that I have, it doesn't hurt like that. You just get that little prick and be finished with it. And I think it worked a lot better than the other ones, and I'm not even familiar with the other ones.
Another question for you, Dr. Illick. For patients who have already experienced complications or frustrations with an access, what message would you want them to hear today?
Well, independent of Xeltis, the message that I've crusaded on is there is always another option, and don't give up. Many people out there who do this casually do it very well, but many, many, many people who do it casually do not. And I would very strongly urge patients, especially if they've had failures, to seek out what we call comprehensive dialysis access centers. These are centers that truly concentrate on dialysis access, that view this as a holy war, view it as the Jedi against the Sith. Our center is one of 5 or 6 that we do nothing but dialysis access. I spent 20 years at the university in both Tampa and Rochester, and even though our intentions were the best, we still would be stuck doing this in the middle of the night, and we'd be bumped by trauma, and the junior person would do it, and nobody would really take care of these people post-op. And when you get to a center that really takes this seriously, all of those things go away. And what's very important is you've got docs that follow these accesses over the years. So I would say there's always a plan B, always a plan C, always a plan D, but sometimes you gotta go outside your comfort hospital and sort of seek out the people who do this at a high level, very serious kind of holy war type mentality.
And my last question for you, what guidance would you give patients on how to engage their healthcare team in discussions about vascular access options? Specifically, how can patients learn about the full range of access choices available to them, including new innovations, so that they can make informed decisions and advocate for the options that best fit their medical needs and lifestyle?
So, great question, and one that we hear all the time. There is no perfect answer for that. Some docs are wonderful, and some docs are jerks. You can also find people that sort of rush through the visit, and some people who sit down and talk with them. I would start with Dr. Google. You can't believe everything you read, but at least that can give you a decent overview on peritoneal dialysis versus hemodialysis, various combinations. At the other extreme are the medical textbooks, Principles of Dialysis Access being the main one. Things like that are usually readable to lay people, but you really kind of gotta fight through a lot of stuff that may not be applicable to you in order to find the gems. Once again, I think the best possible way is to seek out a provider or a provider team that takes this seriously. The first thing that I always ask patients in the office is, have they explained what's going on here, or did they just say, go see this guy? And 90% of them say they just said, go see this guy. And so we always start each visit by discussing what dialysis access is and how hemodialysis works and what our options are and so on. We'll generally identify with ultrasound what the best options are. Certainly it's the patient's choice, but I can discuss sort of the pros and the cons and all the things, pluses and minuses that go into making this decision. But I think there's no recipe that fits all. I would be persistent. I would seek out a provider that concentrates on this, that takes it seriously, that doesn't just view this as a throwaway thing.
I wanted to extend a heartfelt thanks to Dr. Illick and Reginald Robbins for being a part of today's program. If anyone watching has additional questions for our speakers or about today's webinar that we were unable to get to, please email us at info@aakp.org, noting the webinar title in the email subject line. Before we close, we'd like to share information about Access Clinical Study. The Access Pivotal Trial is evaluating an investigational dialysis access designed to gradually transform into the patient's own living blood vessel. The study is looking at whether it may help reduce infections, lower complications, and decrease the need for repeated procedures. If you are on hemodialysis and need a new access, you may be eligible to participate. Participation is voluntary, provided at no cost, and compensation for time and travel may be available at select research sites. The procedure is similar to standard graft surgery, followed by scheduled follow-up visits, so researchers can monitor safety and outcomes. The study is overseen by regulatory and ethics review boards to ensure patient safety. To learn more about this clinical trial or see where research sites are located, visit usa.accesspivotal.com/enrolling-centers/. The website is right there on your screen. If you are not already a member of AAKP, we encourage you to join. AAKP offers free membership to patients and their family members, as well as living kidney donors. To become a free member, join online at aakp.org/join or by phone at 1-800-749-2257. To receive all the benefits of membership, please be sure to include your email address when signing up. As an AAKP member, you will be notified about all of AAKP's upcoming events, the latest in our educational program series, and when opportunities arise where your opinions and experiences are needed to inform innovation, advance care, and make a meaningful impact to improve lives. We encourage you to respond to our flash surveys and other engagement opportunities to help us elevate the independent patient voice and change status quo kidney care. You will also receive a digital subscription to our bi-monthly magazine, AAKP Renal Life, and can select to receive any of our 5 different electronic newsletters, all for just signing up. We also invite you to check out our blog to read some great articles and patient profile stories, and follow us on social media for all the latest news and to keep up on what's trending. AAKP is dedicated to helping kidney patients across the disease spectrum understand their condition and take control of their healthcare. We are proud to offer a variety of resources for both patients and care partners. By visiting our website at aakp.org and clicking on the AAKP Store button at the top of the homepage, you can find a variety of educational brochures and online tools to order or download free of charge, including titles such as Questions to Ask Your Doctor About Dialysis Access Options or Understanding Your Hemodialysis Access Options brochure. You can also order materials by phone. We are excited to announce the dates of the AAKP Policy Summit. The 9th annual AAKP Public Policy Summit will be held on July 23rd at the National Press Club in Washington, D.C. Registration for this free event is now open, and a virtual option is also available for those unable to join us in person. We are also excited to announce the dates of the AAKP National Patient Meeting are September 11th through the 13th. This annual event is taking place at the Little Rock Marriott in Little Rock, Arkansas. The AAKP National Patient Meeting, the largest kidney patient conference in the U.S. with a growing international audience, featuring a diverse lineup of speakers crossing all sectors of the kidney community. Visit the AAKP website for more information as it becomes available. Registration and housing will open soon. Please continue to visit our website and follow us on our social media channels to be kept up to date on the latest event information. And finally, you can visit our special AAKP on-demand webpage at bit.ly/AAKP on-demand to watch a number of great presentations and webinars, all available on demand from our 2025 events and programs, as well as 2026 programs as they occur. You can also visit the AAKP YouTube channel at bit.ly/AAKP YouTube for more great content. AAKP thanks Xeltis for the sponsorship of today's program. We would also like to extend a heartfelt thank you to our webinar speakers, Dr. Carl Illig, Paul Conway, and Reginald Robbins, for graciously participating in today's HealthLine event. Their expertise and insights greatly enriched the discussion and provided valuable information. And thank you to everyone who joined us.